We just wish to ensure that our community knows that our two area hospitals present here and this department, Linn County Public Health, are working in partnership with national and state health agencies to address any issues which include fever, vomiting, diarrhea, severe headache, muscle pain, weakness, abdominal pain, unexplained bleeding or bruising. The Linn County Public Health, in conjunction with the Iowa Department of Public Health, is constantly updating and revising our preparedness response to all communicable infections, including Ebola. We use contact tracing on a regular basis to follow up on many communicable diseases. We have a strong working relationship with both hospitals in Linn County and with our community partners to collaborate and protect the community should Ebola or any other communicable disease present in Linn County. Yesterday, October 20th, Linn County Public Health was notified from the Iowa Department of Public Health that the Centers for Disease Control and Prevention and the Department of Homeland Security, Customs and Border Protection will begin new layers of entry screening. Enhanced screening procedures for passengers arriving to the United States from Sierra Leone, Liberia, and Guinea will begin on Saturday. These airports, as you probably know, are in the cities of Dallas, Chicago, New York, Atlanta, and Newark. Information regarding passengers arriving from these countries will be sent to the state that they will be visiting in or returning to. Persons returning from one of those countries where transmission is ongoing and who potentially came in contact with an Ebola-infected patient will be placed in mandatory home isolation for 21 days. Number one. Number two, persons who travel to one of the countries where transmission is ongoing and did not have contact with an Ebola-infected patient will be placed under an order of self-monitor. These persons will be required to report their health status to local public health departments twice a day. These individuals will only be allowed to travel on mass transportation in special circumstances and with the written approval from the Iowa Department of Public Health. At this point, I would like to introduce Dr. Mark Valier, Senior Vice President of Medical Affairs and Chief Medical Officer at Mercy Medical Center, as well as Dr. Dustin Arnold, who is at UnityPoint, Cedar Rapids, Chief Medical Officer. So first, I would like Dustin Arnold to go.
As a medical community, infectious disease preparedness is a priority. Like hundreds of other hospitals across the country and the world, we have ramped up our efforts even more in recent weeks. While the likelihood remains very low that a patient with Ebola will present to area hospitals or clinics, we continue to refresh staff and ready ourselves. The safety of patients, medical staff, hospital visitors, and the community is our utmost priority. These past weeks, we've been working closely as healthcare organizations to put in place initial protocols for improved screening at key entry points to the hospitals and clinics, as well as a process for handling a patient suspected of having Ebola. This has been done to decrease the chance of exposure and to ensure proper communication. A new screening tool is used for those seeking care or those presenting with an obvious illness at either hospital. They are asked if they have a fever and whether or not they've traveled to West Africa and if they've had contact with anyone who has Ebola. If so, we have protocols in place to isolate the individual and protect staff with personal protective equipment. Both hospitals have also implemented a travel-borne illness or rapid response team internally, which is actively receiving ongoing training. Our travel screening is a critical part of frontline intervention. Again, I want to stress that it's extremely low likelihood that we'd have a case in the community and that it is not transmitted through casual contact.
Okay, now Mark.
Although the likelihood of somebody presenting with Ebola is very small, as you've heard, we want to let you know that there are focused work groups here in Linn County to address this threat. Preparedness is our first priority. As you've heard from Dr. Arnold, we've deployed resources and we have the latest information on the virus. We've put new screening processes in place at points of entry in both hospitals and in all the clinics. We have protective gear in place and facility preparedness in place. We continue to expand our hand hygiene stations within the hospitals and clinics. In conjunction with Linn County Public Health, Area Ambulance, Cedar Rapids Fire, and other community partners, our priorities in doing this work are no doubt going to need to change as new information becomes available. But we will remain focused on colleague and patient safety, clinical readiness, and communication. Concern over Ebola is coming at an interesting time when we're also ramping up for our influenza season. And I'd be remiss to not take this opportunity to urge individuals to take part in the influenza vaccine campaigns that are going on. Influenza season is unpredictable in this area and can have serious consequences. According to the Center for Disease Control, it's estimated that 5 to 20% of people will experience influenza, and more than 200,000 people are hospitalized each year with complications from influenza. Of course, heightened global awareness of any illness is good to remember the universal precautions which healthcare providers use to protect themselves. Those include frequent hand washing, the cover your cough using elbow or a tissue, avoiding close contact with those that are sick, staying home from work whenever possible when you are ill. And we'd like to wrap up with a few comments from Pramod, and then we'll give you the opportunity to see some of the personal protective equipment that's being used in area hospitals and clinics.
All right, so as a public health agency, our really mission is to keep our community healthy and free from disease. So again, it's so important to note that while this virus raises the level of concern for all of us, it also provides us valuable opportunities for training. It gives us a chance as a community to refresh and practice our skills, which we do all the time, for the next public health threat that comes along. Please remember, the Ebola virus poses very little risk to our community and to the United States in general. Only one imported case has been reported in the United States. Casual contact does not spread the virus. Again, I'm repeating the same old thing. Contact with bodily fluid from an ill person is required for transmission of the virus, transmission of disease. We will continue to take guidance from the Centers for Disease Control and Prevention. Those directives will likely change as we go forward and will need to be flexible to adapt. All right, so at this point, you are welcome to see the demonstration here of personal protective equipment, PPE, and we can also try to answer questions if you have.
And I'll make the introduction of Lori Townsend, our infection control nurse at St. Luke's in Cedar Rapids. So Lori, if you want to demonstrate that.
Sure. We have a sample here of the personal protective equipment that our employees would wear to protect themselves for their safety. And this can vary based on the organization and their suppliers, but just because you see this here doesn't mean you see it in every facility. They will vary. The main important part is to make sure that every part of the body is covered and that no skin is exposed. We've done that here with a face mask and a splash shield, a hood cover to make sure the neck is covered. We have double gloves. We put the longer pair of gloves over top, so when we remove them, they're easier to remove. We have a fluid-resistant jumpsuit. We have boot covers. And as I mentioned, depending on CDC guidelines, we may change whatever personal protective equipment we are using to meet those guidelines. Because things have changed even as of yesterday afternoon. So what you see here today may change just a little bit, but for the most part, the main key is really making sure the entire body is covered and that the equipment is fluid resistant. Thank you.
Thank you, Lori. So if you guys have any questions, we can try to answer those. Yes.
You talked about new screening tools that you have at the hospitals. Have you had to enact any of those with people who have come in recently?
New screening tools at the hospital.
With the Ebola question going back probably to September, and then with the case in Dallas, at that time we we always have preparedness for dealing with any sort of infectious disease. But at that juncture, we took a look at our gap analysis and then filled in that gap. So we have been following those protocols for the last several weeks. We started our screening with the CDC guidelines, which have been revised in the last week, but we've been consistent with that. And then our actual personal protective gear, we've started off, and I think both hospitals have both started off closer to WHO guidelines, World Health Organization, which recommend no exposed skin. So we've been ahead of this, yes.
You mentioned that you have kind of used this as an opportunity to like update and refresh protocols. What are some examples of things you may have changed or updated?
Well, the things for people that work in emergency department or whatnot is they're constantly exposed to people coming in with contagious diseases. And it may be something as simple as a common cold, you know, it may be something slightly more serious as influenza, it may be right up to the Ebola. So it is a reminder to just make the assumption everybody coming in is a potential contagion. Do the hand washing, avoid the contact without gloves. I mean, it's amazing anymore, whether it's a first responder, fire department, policeman, anybody, you see them getting gloves out nowadays. And, you know, that, again, it doesn't have to be Ebola. It can be any one of a number of things. And this is a great reminder for everybody.
I would say to follow up on that, some of the clinical staff caring for the patient, not much has changed for them as far as protecting themselves, other than no skin exposed. But there's also other staff that care for these patients. So I would say in our gap analysis, we've had closure on how the lab handles the collection of samples, how the rooms are cleaned afterwards. So we have escalated that from a standpoint of what we probably would have done prior to this.
What are some trainings that nurses and medical staff have been going through to prepare for this?
Well, we have started with breaking up in 4 elements caring for these patients. And the first is recognition, and that's using the CDC screening tool to recognize the patients that has been common, the fever and the travel history. And that's followed by isolation of that patient. In that situation, we have staff that has been trained to don and doff or take on and put on the suits in a buddy system with a third person watching to make sure that they don't contaminate their cells or their buddy, so to speak. And then in addition to that, we've taken measures to isolate the patient within the hospital, and each hospital has a designated area. So in the event that we would have a patient that would have Ebola viral disease, they would not be in a common area with other patients. Collaborate with the county and state health departments. And then as of today, and I don't believe it's changed, that if we would have someone that was truly with active disease, they would go to one of the designated CDC quaternary centers for treatment.
You mentioned the symptoms for Ebola, your muscle aches, your vomiting, your nausea. I mean, these are very similar to flu or some other viral infections. At one point, should people start thinking this could be something a little bit more than that? Or on the other hand, when there is an epidemic like Ebola, common, every day people would start thinking, okay, I must have the worst of the worst. So at what point should people should they go to a physician earlier, get this checked out earlier because of what's going on?
It's really the 2 components. I mean, the fever, the weakness, the muscle ache, the nausea, the vomiting, you're absolutely right. Or 99.9% it's something not Ebola. So the fever is the most common symptom. 90% of sick Ebola patients have fever, so that's the one trigger. But the other is the travel. So if I have fever and any one of those symptoms, but I haven't traveled to an endemic area and haven't been around anybody that's traveled to an endemic area, then my chances of having something serious like Ebola are essentially nil. So it's the fever and the travel history or exposure to a traveled person that are the 2 screening questions to key on. The rest of it, yes, somebody may have that, but it's not specific enough to generate a worry.
And the hospital possesses laboratory diagnostic capability to confirm influenza, parainfluenza, other respiratory viruses that may be prevalent in the community rapidly. So even if you would present with those symptoms, we could confirm that it was influenza or another respiratory virus that was active in the community.
Have you quarantined or isolated any patients recently?
We've had no
No.
suspected cases of Ebola in Linn County.
We haven't isolated anybody at Mercy for Ebola.
I mean, one of the very important things in any disease investigation is that you do contact tracing. So if somebody, as Doctor said here, if somebody has traveled to Western African countries, and if he or she was exposed there, then and presenting with these type of symptoms, then you have high attention or a big concern with that patient. And then if that patient has multiple contacts after coming here or exposed to other folks, then there would be another series of contact tracing. So you have to rule out some of the variables before declaring anybody danger free.
I think something to be careful of in the rumor mill is, if you walk down the hallway at either of the two hospitals, you will see people in isolation.
Right.
If somebody comes in with influenza, they go into respiratory isolation. If somebody has methicillin-resistant Staph aureus, a skin infection, they will be in isolation. So we have people every day in isolation, just not for this particular illness. So if somebody were to say, oh my gosh, there's an isolation patient, do they have? Probably not.
I would say the difference with Ebola is that typically they're in isolation and healthcare providers don gowns to protect them from transmitting one disease, one bacteria to another patient that they're caring for. So that's why the WHO guidelines we felt were more acceptable because of the no exposed skin, because actually now you're not only preventing transmission to another patient, you're preventing the healthcare provider from getting it.
How often are these guidelines changing now? I feel like every day we're hearing CDC has changed guidelines on this, or they're working on this. I mean, how are you keeping up with that, and how are you making sure that you're abiding by all those changes, and are they changing things often for you all?
Well, as we said when we did our gap analysis, going back probably in September, decided that the WHO guidelines were probably more acceptable because they have more experience, perhaps. But we have direct contact with the public health department here as well as the CDC to continually update that.
We get alerts from Centers for Disease Control and Prevention and also IDPH. So we constantly abreast with whatever is happening there. So we informed our medical providers here as well. So it's very timely. We do this in a timely manner.
You all work on front lines. What is the fear level in the community of Ebola?
I would say high.
I would say high, and I'll refrain from, I think there's been some stumbling with the CDC to have a consistent message, and that's caused some problems, and I think they've closed their gap on that. But just a case in point, I believe yesterday we passed the 21-day mark for Mr. Duncan in Dallas, and none of the people that had casual contact with him, household contacts, contracted the illness. So that demonstrates that it's even with contact, not caring for, but contact with a patient that has it casually, it's not transmitted.
Yeah, and it's a tribute to our medical care system here in this country. So, contact tracing, we did an outstanding job with that. So
Would you say your staff is safe? I know there's been a lot of stories about people in Dallas and concerns with the medical professionals there. How confident are you that should something like that happen here, that the nurses and the doctors are safe?
Well, I think it's providing them with the best equipment that we can, continually having them drill so that they're used to, donning and doffing, putting on and off the equipment. As Dr. Arnold mentioned, the buddy system. So somebody is going to sit there and you're going to rotate around and they're going to make absolutely sure there is, no exposed skin. So we're trying to reassure them that they're being...
Membership at this time, just just out of that, we want people that are aware of the dangers. We wouldn't want someone to feel like they were forced into caring for one of these patients, and we've had a good response that we probably would not needed to have a volunteer status. So I'm very confident that our staff is protected.
And how often do you all kind of revisit, the guidelines with the staff? Is it weekly, monthly, daily?
We have a weekly meeting right now with the department heads and service line leaders, and that's followed by a medical staff meeting right after that with their leadership and input. And then I would say our executive team meets quite often.
And
But
there is
the messages are going out daily
Yeah.
and new things come up, so.
and there is a public health preparedness drill also we conduct in the community with area hospitals and also other partners as well.
Partners like emergency, like firefighters and
Emergency management and
Yeah.
fire, police.
Yeah, area ambulance has really done a lot of work to get prepared for this. They have a special team. They have a designated ambulance for transport of any patients suspected of having Ebola. They've made arrangements with the hospitals, where to go, how to offload the patients. So, a lot of work in the community outside the hospitals is going into this planning. So they should be commended for
Absolutely, yeah.
being very proactive.
Area
in
ambulance
this.
has always been a good partner, but I mean they really have been a leader from that side of pre-hospital medicine.
Actually, one of the diseases that we practiced drill, the drill was completed was Ebola actually. It was recently 2 weeks ago, 3 weeks ago.
Are the trainings mandatory for staff and nurses and doctors to attend for things like Ebola?
There's, we call it net learning, but annual competencies and things like isolation and then universal precautions. So those are mandatory for all of our staff, but there's kind of an increased level of intensity that's going on lately with the people who are on these teams. So these particular kind of hazmat suits are not necessarily standard issue for isolation, so that does require, up training for those people that are going to be on those teams and caring for those patients.
Yeah, I would echo that using the volunteer team, internal response teams, then we have the ability to have that staff proficiently trained and a smaller number of people rather than trying to, having 2,000 employees up to speed. So we've narrowed that spectrum of training beyond the normal clinical competencies that are mandatory.
So what was the interest in that volunteer internal response team, and what are people, do they want to take part in that?
Yes, I think we have more than adequate staffing to cover the volume. We have more than adequate staffing to cover more than the volume that we would ever see in Cedar Rapids, Iowa.
All right, we'll take one more question and then no more. All right, any more questions? All right, well, thank you all very much for coming here and talking to us. And thank you both very much.
Thank you.
Is there any way